Then you get this reactive intermediate and direct toxin-induced liver disease called NAPQI. So acetaminophen is the other part of the spectrum from where we started when we were talking about immune-related drug-induced liver disease. There are a number of different factors involved with acetaminophen. For instance, the CYP is sitting in this microsomal oxidative system, the NEO system, and that can be upregulated by alcohol. So alcohol can upregulate the metabolism of acetaminophen to make it more toxic. Also, glutathione comes in and reacts with the NAPQI, saving the liver from liver injury. But if the patient is starving, glutathione stores will be less, and there'll be a higher risk of liver injury. So you take a patient drinking alcohol who's not eating, low carb, long intervals between carbohydrate intake and protein intake, the lower the chance of having substantial glutathione for protection. All right, now we're going back to idiosyncratic, and I'm really going to use the word idiosyncratic interchangeable with this immune activation pathway. The bottom line is intracellular stress, you have apoptosis, you have autophagy, you have cell lysis that are all involved with this. And it could either be the direct drug or the immune system coming in to cause that cell kill that takes place. So there is a whole world of pharmacogenomics out there that actually tell patients, if you spend a couple $1,000s, they will tell you what challenges that patient may have with different drugs. They'll tell you if the patient has a genetic predisposition to augmentin, as an example, or nitrofurantoin, or potentially acetaminophen, or INH. There are genetic polymorphisms that lead to this, and I've had patients bring me a document that they paid for through a blood draw that tells me what drugs I can and can't use for their case and care. And it's actually quite accurate. People aren't doing it in general just because you have 2,000 or 3,000 drugs on the market, and these genetic polymorphisms only predict drug sensitivity to 20 or 30 drugs. So it's not superbly applicable, but and maybe if somebody's on chronic antibiotics, having chronic UTIs, recurrent pneumonias, et cetera. So we talk about these different phases now, and this is how those modification of different functional groups takes place in phase 1. CYPs are the dominant part of this, and you can see here that CYPs are taking up 75–80% of that metabolic pathway. There are different variants, different genetic variants. This is part of that genetic profiling that I was talking about, and there are racial and ethnic distributions of different CYPs. Second phase is conjugation. This is for excretion or detoxification that can take place. Glutathione S transferases is one of the key part of the detoxifications that take place. And the UGT and the sulfotransferases that we talked about earlier with acetaminophen. You can have variants in phase 2 metabolism. A classic one that you may order is TPMT for your inflammatory bowel disease patients. They have a deficiency of this thiopurine methyltransferase, and that can lead to fatal bone marrow suppression, which I've seen a few times. And I also believe that this has some relationship to the risk of pancreatitis from the Imuran specifically. There's also this arylamine acetyltransferase polymorphism that's implicated in INH toxicity, and hepatotoxicity can be predicted with this polymorphism analysis. Well, if you got a patient you're thinking about giving flucoxacillin to, you can do an HLA and find out if they have this B5701, and that can identify that that patient's at high risk for flucox-induced liver toxicity. Now, it's pretty rare, but I think flucoxacillin is also a rarely used antibiotics. And is it worth doing HLA typing in the hundreds of dollars to find the 1 in a 500 or 1 out of 1,000 to might develop DILI? Now, the way I read this is that if you have HLA-B 5701, only 1 out of 500 of those people who take flucoxacillin will actually get drug-induced liver disease. So this must be a polygenic risk. mentioned augmentin, this amoxicillin, clavulanic, DILI, and GWAS was able to identify some specific HLA associations that are here. So you map this out, you get your drug pharmacogenomics testing done, and you can tell patients that they probably should not take this drug, or if they do chronically or long-term, more than 5 days, which is pretty typical for augmentin, they would change to a different antibiotic or be closely monitored. This is the strongest HLA risk. There's 201 cases with the odds ratio between 2.3 and 2.8 for these two different HLA alleles, but the p-value is very strongly statistically significant. So there are genetic studies that can take place. I'm going to say there must be 15 or 20 drugs that you can identify, risk factors for toxicity. And there's other systemic toxicity. We're just talking about hepatotoxicity today, where this risk is present. All right, now we're going to jump back up to 10,000 feet. So drug-induced liver disease, we've talked about immune, talked about direct injury, but there's a lot of other events that can take place. We talked about cholestasis, so that may be cholestatic hepatitis. There's also the possibility of just bland cholestasis, probably a pure transporter event as opposed to an immune event. Direct cell necrosis, steatosis, NASH. That could be a microvesicular raise type syndrome that you might see in a pediatric, say with aspirin, or pediatric or adults with valproic acid. Sinusoidal obstructive syndrome has been associated with some drugs, mostly chemotherapeutic agents. Nodular regenerative hyperplasia has been reported with a number of drugs. Probably one of the worst ones in that, or most typical one in that group, is back to Imuran. So NRH is another type of liver injury. Talk about these immune drugs, that is drug-induced autoimmune hepatitis early. There's also immunotherapy-induced hepatitis from the checkpoint inhibitors, which are PD-1, PD-L1, or CTLA-4. This could be nivolumab, atezolizumab, pembrolizumab, ipilimumab, which is a CTLA-4. And those can cause a direct turn on of the immune system and trigger an autoimmune type hepatitis. There are two types that you can see with checkpoint inhibitors in terms of the liver toxicity. One is a classic portal-based plasmacytic, predominantly with interface hepatitis. The other is a lobular hepatitis with a centrilobular feature where the central vein undergoes substantial injury. And we've seen that variant of autoimmune hepatitis just spontaneously, and it appears to be more common with the IRAEs, immune-related adverse events you see with the checkpoint inhibitors. This just goes into the toxicity of the ICIs. So elevated ALT is much more likely with a CTLA-4, that's ipilimumab, than the PD-1, which would be nivolumab or pembro, or the anti-PD-L1. An example of that would be atezolizumab, which is at the front line. So a lot of other organs that can get injured with these immune checkpoint inhibitors. A little bit more on pattern. I'm not going to go into this in great detail. And I'm going to move this to Herbal for just a moment, since we're still sitting in that genetic world just a little bit. Here's green tea-induced liver injury, just published with this HLA-B3501. They went through a pretty interesting algorithm here, but they started with almost 2,000 cases of potential and found 70 cases exposed to green tea. And only 40 out of the 70, for about half, were judged through this Delphi method as being definite or highly likely or probable associated with green tea-induced liver injury. This gives you more details. What's important on here is I always like looking at the numbers. So this green tea, that's green tea powder, green tea extract. It's not just the tea that you're going to get out of your cabinet in the morning or find at a Chinese restaurant. Look at the enzyme numbers here, 1,600 for ALT, and ALT is higher than AST, and the ALK phos has barely budged. Peak Billy, though, quite significant at almost 14. Half the patients had an autoantibody. So these are very nonspecific, and it goes back to a great history or liver biopsy or both to help sort this out. So it has to do with whether you have one or two copies. So obviously 2 copies gives you more likely, probable, definite induced disease. Okay. We've gone through DILI. We've talked about mechanisms. We'll talk a little more about histology later. We talked about biotransformations and the key enzymes. It's kind of interesting on this right graph between 2004 and 2015. We've gone from 200 to 1,200 of reported drug-related adverse events to the US FDA. This can be filed by consumers, doctors, drug manufacturers, and part of this might just be a learning curve, more of an awareness of what's going on. Within 2015, 1.2 million cases. It's just absolutely huge. Okay, we've gone through most of this. I do want to highlight on this slide amiodarone, which has historically been with intravenous high-dose amiodarone, where amiodarone collects inside the liver cell into these lamellar-like structures. Drug accumulation then becomes liver toxic. That was mostly with intravenous and high-dose amiodarone. So I haven't seen an amiodarone liver toxicity case in, I would say, 15 years. Augmentin I see every year. Allopurinol is interesting because it causes a granulomatous hepatitis. So that's very different. There's only a few drugs in that class. Aminocycline can cause a mix, it can cause a cholestatic, and it can also cause a fatty liver type picture. Somebody's being really funny. Let's walk through this just for a moment on the right side. The thing that's really relevant to your practice is this acute hepatitis from the fluoroquinolones. So Levaquin, Cipro, nitrofurantoin you're going to be likely to see in practice because it's still very commonly used for urinary tract infections as a chronic suppressant in women. Methyldopa is still out there and can result in a follow-on autoimmune, although that just presents as an acute hepatitis. The cholestatic, especially bland cholestatic, can be found with different hormonal supplements. The androgens are very important because you're going to find these in a lot of food supplements, bodybuilding agents. I think not just found from a plant source, but I think they're adulterated. And that obviously improves sales when your clients are building big muscles. Floxuridine can cause this vanishing bile duct-like picture. As I understand, floxuridine is basically a chemotherapeutic agent. And we talked about amoxicillin clavulanic acid with this cholestatic hepatitis. So it'd be very high bilirubin alk-phos and moderately elevated AST and ALT. I mentioned allopurinol causing granulomatous hepatitis. Another is an anti-seizure medicine that's still reasonably popular, phenytoin. Microvesicular, valproic acid we mentioned, and tetracycline, but moving up one to macro, methotrexate, definitely a hepatic toxic, and I think it's in rheumatoid arthritis, but not in psoriatic arthritis. You'll have to double check me on that one. Tamoxifen is also causing a macrovesicular change. Steatohepatitis is fat, macro, micro, with ballooning, with variable inflammation and fibrosis. Same bad actors that we've talked about already. Acetaminophen causes a central lobular necrosis picture. That's what you would find on biopsy if you were to biopsy these patients. There's plenty of that documented in the literature. Submassive necrosis can be with any drug, but INH can get you there, even specifically in unmonitored patients. Nitrofurantoin is reported, but in my opinion, it's much more causing a mixed cholestatic picture. We mentioned VOD-SOS, sinusoidal obstructive syndrome from a chemotherapeutic agent. So lots to look at, lots to think about, and maybe poison has some intrinsic toxicity, I would say. Listen to this group, so crazy. I think we've gone over acetaminophen, gone over histology. One thing that's very important is that if you have liver enzymes over 2,000 to 3,000, acetaminophen is very likely to be the culprit or a co-contributor. Every patient with acute liver injury has to get an acetaminophen level. I don't care what your history is. There's 30 different products, over-the-counter products that have acetaminophen in them, and only probably 5 out of 30 of the patient actually know what they're taking. Bilirubin doesn't go up till much later, and of course you're going to follow levels, draw a level immediately on presentation, and follow levels every 3 days. You're going to switch from IV to oral for a number of reasons. One is cost; it's much cheaper for the oral versus the IV, and it's possible by delivering it to the liver orally that you might get some better protective effect, but that's theoretical. It's just timing. It's kind of interesting why AST goes up early and higher. But if the AST is more than twice ALT, consider getting a CK or aldolase. You can see here, it's kind of interesting. AST's got a faster clearance rate, so it must be, I believe, a peripheral effect. I've had patients who've gotten a peripheral muscular effect and went into renal failure that we thought was at least partially by rhabdomyolysis. But if you think about this drug, acetaminophen, as being directly kidney toxic, the metabolism can take place in the kidney, you can get the toxic byproducts, and glutathione sits in the kidneys. This is just talking about all the different variations in terms of recovery, and I think this does go back to the issue about patients drinking alcohol or starving or both, or potentially taking cold remedies. There's a lot of other things that can be in the mix in somebody who goes down this pathway, especially if it's accidental. So we have spent $87 million a year treatment acetaminophen overdoses. People have talked about taking acetaminophen off the market, but it's really the safest analgesic and antipyretic out there. If you stay under 2 grams, really under 3 grams, but under 2 grams a day, the risk of liver toxicity from acetaminophen rapidly approaches 0. You always got to take a history about shock, blood pressure, syncope. That can look like acetaminophen. They may be on a little bit of acetaminophen. They get shock from sepsis or something else, a cardiac event. That you might draw an APAP level and it might come back positive, and you go, oh, it's acetaminophen toxicity. Now, making that diagnosis and giving N-acetylcysteine is perfectly safe and reasonable, since the N-acetylcysteine may work in a variety of types of liver injury. Intravenous amiodarone, well, on liver biopsy under electron microscopy, nothing looks like amiodarone toxicity. You have this huge buildup of amiodarone in these lamellar-like structures, and there's some hint that it may not be the amiodarone, but it may have been the polysorbate 80 that contributed to this. But follow your enzymes, follow your function, look at your GGT, fractionate the bilirubin. All right, a little bit more on idiosyncratic. 15% of ALF cases are this idiosyncratic, which are probably immune. I kind of like the word idiosyncratic. It starts with I. Immune starts with I. It does list some other important drugs like Septra, tyrosine kinase inhibitors such as sorafenib, regorafenib, cabozantinib, levantinib, not ramucirumab, leaving one other one off, but there's a whole family of TKI inhibitors that can cause liver toxicity in an unpredictable way. TNF inhibitors also can cause liver toxicity, although we think this is quite rare, well, say with etanercept or related compounds. If the patient has fever plus rash, granulomas plus eosinophilia, that's when you're going to be thinking about intervening with immunosuppression, steroids specifically. Gone through metabolism, did phase 1, phase 2, export is phase 3. That's to the biliary export. Sinusoidal export back into the blood is phase 4. Did phase 1, we talked about phase 2. Already talked about this. Aflatoxin, unlikely to be a big issue. It's kind of interesting here in terms of looking at ketoconazole. It says aflatoxin in the header. I'm not quite sure about this slide. Everything here. So pioglitazone is the only lidazone, thiolizidine, cozolidine diones are still on the market. I don't even use pioglitazone anymore in my NASH patients because association with fluid gain, heart failure, bladder cancer, and osteoporosis. So pioglitazone to me is a bad actor. I don't use it, but it definitely also has an association through this whole family of liver toxicity. And troglitazone, the top one that was here, actually made it onto the market. There was no signal in the first clinical trials, but the clinical trials in diabetes with troglitazone were quite small. As soon as it got into the public setting, within, I think, a year, there were 600 cases or something reported with a number of deaths and transplants. Results in the cell kill with an LDL release. This was in a preclinical model. This is in a preclinical model that would help decide if this was going to be predicted to be hepatotoxic. This is in different assays, and it had all these signals, but it still made it onto the market, interestingly. A lot of modeling is being done. I'm just showing you this one because drug's not on the market, but pharmaceutical companies now do this predictive modeling. They look at these different assays. They're very worried about liver toxicity because if there's significant liver toxicity, the drug comes off the market and they've lost their entire investment. All the fluoroquinolones and Cipro and trovafloxacin are the most common ones that you would be using, but there are some other ones that are listed here. These also have known and predictable liver toxicity, but it's idiosyncratic, meaning we don't understand it, but we will understand it, especially when we do genetic profiling. So this trovafloxacin was the only one that was predictably toxic that I think that was also approved and got pulled from the market. Levo looks to be much, much safer. There's a lot of active areas in here that are related to antimicrobial, but because of the structure too, there's a number of side branches that may allow or predict off-target toxicity. They are looking at doing these stem cells and using stem cells to improve understanding about drug metabolism, but more importantly about drug-induced liver injury to be able to predict this. This was published a couple of years ago. So I capital idiopathic, I little immune related. But idiopathic typically is an immune related event in a rare but genetically susceptible individual. This goes through a bit more detail on the T cell issues and memory. One second. This is another gene that was a risk factor for augmentin. So this hypersensitivity / drug-induced AIH, hypersensitivity may be more of an eosinophilic response associated with rash and arthritis. Whereas a drug-induced AIH would end up looking more on biopsy with this plasma cell, severe interface hepatitis, or maybe even a central lobular hepatitis with a central vein injury pattern. This also just talks about not every patient is ANA positive, not every patient has an elevated IgG, but the AI score being greater than 2 is seen in a number of these drugs, including nitrofurantoin. The AI score has to do with what's happening, history, labs, and liver biopsy. But biopsy still is really important to make this determination and justify moving forward with steroids, which again are rarely used in drug-induced liver disease, but can be useful in these very specific cases. This is just going over some more of the autoantibodies and IgG levels. Let's see if there's anything else on here. We covered all of those. GWAS we covered. UDP glucuronosyl transferases can be phenotype. Oh, why this is important is you might be working up somebody for Gilbert's. You come up with a polymorphism in Gilbert's. There are some polymorphisms that may make the Gilbert's patient more susceptible to some types of drug-induced liver injury. But you have to do the modeling to figure that out. You have to go through one of these drug toxicity panels to establish that. You can't just do it. Say, oh, you have Gilbert's, you're going to be more risk of toxicity to certain drugs. Biopsies, this is somebody being very funny again. But this is really nice histology, very bland bile plugs, no inflammation, central vein here normal, sinusoids normal, nuclei are normal. And this is a classic pattern that you would see from people going into one of the nutrition stores where they have these bodybuilding supplements, and they're full of different types of testosterone derivatives. Then you go to the cholestasis model, and this is a hepatitis cholestatic model because there is inflammation. You have bile duct proliferation. You do have bile duct plugging. You have inflammatory cells around those bile ducts as well. Can even go all the way to bile duct infarcts. Here's a steatohepatitis picture from amiodarone. On the upper right corner is the electron microscopy picture of these lamellar bodies of accumulation of amiodarone and potentially influenced by that polysorbate. On the left, well, it could look like just a pretty severe MAFLD, metabolic associated fatty liver, or it could look like alcoholic hepatitis, but there is just a lot of ballooning. Mallory-Denk bodies don't tell you a whole lot. These are accumulations of ubiquitin and can be seen very commonly in fatty liver, but also immune-related events. SOS, this is a centrilobular necrosis zone. Hepatocytes are there. The central venule, it's got this very thickened wall you can see on that right at higher power. A lot of reactive fibroblasts that are here. There's a number of chemotherapeutic agents, especially for leukemia, that are in this family. NRH, you need a really big biopsy and you need a reticulin stain. There's these expanded and compressed liver cell plates. And I mentioned that this has been seen with Imuran, it's been seen with mycophenolate. Those are a couple of the drugs I think about with NRH. Cholestatic hepatitis, a lot more inflammation than you saw with that previous. We had the bland, we had the mild cholestatic, then we got a more severe cholestatic picture. In the lower right corner, I'd even say that looks even like maybe like a small granuloma that's starting to form. Cipro. Great, just one of my other team is watching this, which is great. This is a cholestatic hepatitis with ciprofloxacin. Got this lymphocytic infiltrate, no plasma cells. It's very important. No eosinophils that are here. So you would just put this person on support. You put them on diet, eating, good calorie intake. Maybe consider URSO. URSO is the farthest I go in terms of drug treatment for drug-induced liver disease. Just trying to figure out how to get this to go forward. There we go. Somebody also being pretty funny here. Biopsy. Watch, don't overinterpret your biopsies. I think maybe it's the big message here. So Augmentin was an interesting case because amoxicillin had already been labeled as a potential hepatotoxin, but 3 per 100,000 prescriptions. And then you go up to Augmentin and it's 17 per 100,000 prescriptions. I'm kind of correcting the numbers here just slightly. And rechallenge, of course, is going to wrap up Augmentin, although it's unlikely you're going to do that. If you have this cholestatic hepatitis and they're on Augmentin, you're going to say, you have liver toxicity from Augmentin, and you're just going to close the door and label their chart. You're not going to be doing genetic or polymorphisms or HLA typing, but there is these clear associations. And these patients can be quite sick. Fluoroquinolones we talked about, but if they have this rash, fever, eosinophilia, you're definitely going to be, in my opinion, should go down the road of using steroids. Oh, actually, one really important issue on here. If they have a bad reaction to, say, Cipro or Levaquin, they are in a class effect. They should be labeled as allergic to fluoroquinolones as a family, and they should not be given another one in the same family. Amiodarone, I think we covered everything. No, it's unlikely you're going to see amiodarone because most of it's oral and much lower dose. So statins used to be labeled as liver toxic, and what happened was is people didn't have liver tests. They were put on a statin, and then somebody got liver tests, and then they were elevated. But in almost all those cases, in my opinion, historically, it's had fatty liver. So 35 randomized studies, 74,000 people, 1.4% had elevated enzymes versus 1.1% of controls. So the risk here of 1.05 statin group, 1.14 statin group versus 105 a placebo group makes statins look extremely safe. The black box warning was removed. And now we give statins to all of our liver patients, especially our cirrhotics, as a liver protective agent, as something that protects against liver cancer. No longer do we monitor these patients. Baseline tests you're always going to have in a statin patient because you're going to be working them up for metabolic associated fatty liver disease. So acute liver failure, 1 per 1 million patient years. That's how safe statins are. As I mentioned, they're really liver protective. Methotrexate, the American College of Rheumatology recommends evaluation for liver disease and fatty liver. I really think methotrexate as a liver toxin is really enhanced by the presence of having fatty liver. Folate decreases the liver enzymes. There's some theory that it's autoprotective also. Monthly for 6 months, then every 3 months. Stop methotrexate or biopsy if the ALT increases to 3 times upper limits of normal or 3 times baseline. If someone's running 50, you would be concerned if it got over 150 as an example. They were doing routine liver biopsies in the past at 1, 3, and 8 grams, but I'm going to say if I see patients on methotrexate, I'm going to follow their enzymes. I'm going to get a CAP score, be doing FibroScan or elastography, seeing if their elastography is changing, see if their CAP score is changing, see what's happening to their enzymes. So I'm going to be biopsying less. This is just what it looks like with this macrovesicular fat, lobular inflammation, nuclear pleomorphism, pericellular fibrosis. And you can see this in alcohol. You can see this in metabolic-associated fatty liver disease. And I think it's rheumatoid arthritis. Let's see, it's just talked about, oh, this is following psoriatic disease. 18 on treatment biopsies at 1,500 milligram intervals, pretty low grade event. Enzymes did go occasionally into the 100 range. There was some correlation with enzymes with grading, but pretty poor correlation that's here. Cumulative methotrexate dose versus biopsy grade is highlighted here, and not really good association. I think this is really messy because fatty liver from metabolic associations, fatty liver from alcohol, methotrexate causing fatty liver. It gets very confusing and very messy. Older age, women, higher milligram or gram dosing, cirrhosis are 4 factors that increase the risk of drug-induced liver disease. Drugs in cirrhosis, narcotics, tramadol, you're going to use at half or third dose. Obeticholic acid used for primary biliary cirrhosis. Now there's a black box warning not to give OCA if people have portal hypertension, current, or a history of liver failure, because OCA is directly hepatotoxic at higher dose. This is OCA, a farnesenoid X receptor agonist that's used for PBC. Intercept submitted an application to the FDA for OCA to be approved for NASH because they met their endpoint of improving fibrosis. The FDA was so concerned about this hepatotoxicity that they sent a letter to the company saying, no, we're not going to approve your drug. You need to submit more safety information. Another interesting thing about obeticholic acid, this may be liver related indirectly, but it increases cholesterol, especially LDL cholesterol, and lowers HDL cholesterol. It's not really a toxic issue. We're going to skip this cirrhosis if you're not going to do it. A little bit more on drug-induced liver injury. This is back to checkpoint inhibitors. Just looking at the number of patients who had hepatotoxicity, it's only 2% had ALTs that went to more than 5 times upper limits of normal. So we'll say it's 5 times 30, 150. 150 becomes an alarm value, a cut panel that I think about 2% of people getting these PD-1, PD-L1, CTLA-4 had liver toxicity risk. So it's very low. CTLA-4 was the bad actor, but the combination of a CTLA-4 with a PD-1 or PD-L1 was the worst actor, and that would get you up in the 9% range. If patients have grade 3 or grade 4 liver enzymes, which is a combination of ALT and bilirubin, those individuals would have their ICI therapy stopped. So it's actually quite a few people who did hit this that got sick enough that you wouldn't be giving them immune checkpoint therapy further. We covered all of those. So we're getting close to the end here. I didn't talk about Hy's rule, but Hy's rule is what's used in drug toxicity to be looking at enzymes and bilirubin to decide if that drug toxicity hits the Hy rule, and the combination of enzymes and bilirubin predicting a high mortality rate hit Hy's rule. The FDA does this calculation and says your drug's not going to be approved. So monitoring for liver toxicity is standard in drug development, and there is a threshold. You hit a certain point because the mortality rate jumps up exponentially. The drug will not make it out of the gate. And we haven't had drug-induced liver disease, predictable drug-induced liver disease in the last 5 to 7 years, other than obeticholic acid in terms of drug development that I can recall. A little bit on herbs. My search was there's at least 50 or 60 herbs that are associated with liver toxicity. Many of them are idiosyncratic, meaning the Chinese people and many other people are taking these herbal supplements and nothing happens. So there probably is some polymorphism as well as lack of standardization and challenges in terms of causing some type of adulteration or lack of monitoring where a source was. Comfrey, upper left corner, common. Yerba tea and mate tea are super popular now on the soft drink or health drinks. But there hasn't been a huge number of toxic cases linked to these, or those would have been pulled from the market. So I don't understand why these were published 20 or 30 years ago from a liver toxicity perspective, yet they're being sold now commonly as a soft drink substitute, actually. This Disacoto lower left corner came out as an herbal supplement, but that's been pulled. Inside that is this Scutellaria, which comes from I think a mushroom, a toxic mushroom. And glycyrrhizin comes from licorice and can cause hypertension as well as liver toxicity. Green juice, we talked about green tea. Germanders and a lot of teas and capsules is something else that can cause acute and chronic hepatitis. Kava, very common in the South Pacific, can cause liver toxicity. Again, it's idiosyncratic. It's kind of an entertainment drink in lots of settings. So I'm sure has to do with some type of polymorphism. Kombucha is, everywhere. It's this yeast bacteria aggregate that makes this health tonic. But when they put a toxic mushroom in that of some type of adulteration, that led to significant liver injury, but we don't have any histology. Second from the bottom, these weight loss, fat burning programs had ephedra. There were some other contaminants that were part of that as well. Let's see. Nothing there that stands out. Nothing there that really stands out. So weight loss agents are a classic group. Monte T, we talked about, Comfrey. These are usually, in my opinion, high concentrations or herbal extracts. There's some garlic extracts also that led to major liver toxicity. Back to Hy's law, this is 3 times ALT, 2 times upper limits of bilirubin, much higher chance of mortality, liver failure. So really what people are thinking is, instead of waiting for the bili to go up, you should really look at Hy's law as just the extract of the ALT. You got a patient that's running 30 or 40, you give them a new drug that's in development through the FDA, and their ALT jumps to 100 or 120, you don't need to have the bilirubin go up to say this is high, high risk for drug development challenges or drug approval. There's a Temple's corollary to Hy's law, and this is where we talk about the ALT, just using the ALT alone to stop a drug development. It does not cause ALT elevation. It does not have a liver liability. They do what's called these E-dish, which takes into account Hy's law, and then this bilirubin upper left alone. Upper right is ALT plus bili. Lower right is just ALT. You can look at where these different drugs are and where these fall into these different pipelines. And this has to do with the drug that's in development. And you look at all the different out there. So drug X is going to hit Hy's law, not going to be approved. Drug C is not hitting Hy's law except for one case. Definitely a number of cases of hyperbilirubinemia and a large number of cases of ALT elevation. I'm sitting at the FDA. I'm not going to let drug C out on the market either. So this is back to Hy's law. Oh, just Buddy Sussman helped me with the slide deck. So we have 5 minutes for Q&A before we wrap.
Dr. Gish, I was just going to ask, like in the beginning when you mentioned the HLA, have you clinically ever used that? Like if, for example, you're suspecting a patient maybe drug injury or liver injury due to green tea use, have you ever clinically checked the HLA?
I have not, but I've had patients who've come in with both their HLA and a whole pharmacogenomics test. There was a company, still probably exists in Colorado, that will do that for you. So I'm going to say I haven't, but if a patient brings it in, I am definitely going to look at whatever that result is and then use that to educate the patient. I'm trying to remember the case. I think it was somebody who was told that they need to be on chronic antibiotics for UTI or recurrent pneumonia or something. And they paid the money and said, okay, here's what this results show. High risk for Augmentin, medium risk for Septra, medium risk for one of the penicillin like flucloxacillin, and low risk for, another class like cephalosporin. So we said, okay, cephalosporins is what we're going to be using for your management. Sound good?
Thank you.
For people online, we're getting back into the cycle here, and Dane Shoemaker's on from Santa Rosa, one of the places I have one of my outreach clinics. So thanks for allowing me to bring more people onto this. And thank you, Joe. Thank you, Gordon, for your leadership and teaching, and the rest of the fellows. And are we set pretty well, Annie, for the next couple of months? With
You hear me, Robert?
Go. I can hear
Hey,
you.
first, can you send me the slides if you don't mind to share it with me?
Yeah, we send these out to everybody. I send them to Annie.
Okay.
I'm going to resort this deck just a little bit because I haven't actually gone through it orally. I've looked at it, so I'm going to resort it. I'll send it to Annie. Annie will send it to everybody. Sound good?
Yeah, that's good. I have a question in that regard. I mean, this is a huge subject as far as for us to remember all of the effect and side effects of everything that surrounds us. There is a problem, though, with the increase in the NASH or the fatty liver. Uh, and on top of it, you get some medication effect. How can you how can you say that this is due to medication versus the fatty liver and the NASH that's going on? How do you change? How do you make a difference between them? When do you start worrying about it?
So
People that already have some problem.
That's a great question, Joe, and I'm going to add a slide in here that this drug-induced liver injury is a rule-out diagnosis. So number one is you take a history. Number two, you suspect a drug because you go onto the liver tox website that's part of the NIH or FDA. You look up the drug. It looks like it's got a moderate to high association. You stop the drug. You work up for hepatitis A, B, C, Wilson's, autoimmune, potentially other viral syndromes like CMV or Epstein-Barr, if clinically indicated. You don't need to do that for everybody. Then you circle back and come back to the drug effect. So I'm going to add in a slide here about the liver tox website. I'm going to add in a slide about the other workup you need to do before you absolutely say this is drug-induced liver disease. And that's going to include an ultrasound, because you're going to, especially in a cholestatic or mixed picture, you're going to have an ultrasound, making sure they're not obstructed. So don't forget the rest of the workup, and I'll make sure I add that slide in.
Hi, Dr. Gish. I had a quick question, just because during your presentation you had mentioned that you haven't seen amyloid toxicity in 15 years, and I think we were suspecting a case at the VA. So I just wanted to, I guess, get your opinion really quickly. So I guess
What drug was it?
amiodarone.
Amiodarones, oral or IV?
Well, initially on IV, but it's been on chronic oral for several years.
Okay, so the only way to figure that out is to do a liver biopsy and do electron microscopy to be absolutely sure. Because you do the biopsy, you're going to see fatty liver. Well, it could be alcohol. A lot of people in the VA have got risk factors for metabolic associated liver disease. So if it's life or death, it's the only antiarrhythmic that's available versus something you have to get from Canada or France or something. Then you're going to need to get a biopsy and justify stopping the amiodarone. But the biopsy and electron microscopy will be classic, or they don't have it.
What if you just stop the medication and it improved? I guess that's not enough to.
It's a lot. That helps you a lot, sure. As long as they don't die from their arrhythmia.
Thanks.
Dead patient's not going to help you much with that assessment. So And amiodarone, intravenous was standard many, many years ago. It's not used too much anymore. Or maybe it's used just for early control for a week or two until they're on oral. That's why the toxicity profile is much less. When I was training in the 80s and early 90s, we saw a lot. I must have seen 10 or 15 cases because part of our training was at the VA, and the VA we used more than we did at the university hospital. I'm not sure exactly what the reason was. Maybe the cardiologists we worked with.
Thank you.
Great question.
So, Dr. Gish, earlier you mentioned like using ursodiol for cholestatic liver injury, or drug-induced. How often, or do you have a specific criteria on when you would start it?
Yeah, bilirubin over 5 lasting more than a week, bilirubin over 5 more than a week increasing while enzymes are getting better. Those are all things that would be, so high bilirubin is really, really key.
Got it. Thanks.
Other questions?
Sorry. And just another question. So for drug-induced autoimmune hepatitis, how often do you find that you have to not just stop the medication but use steroids as well?
Under 5%.
Oh, interesting.
If this classic immune-related, I'm going to see with checkpoint inhibitors, that's the most common. And I would say it's used to be 1 or 2%. Now it's 5% because of the PD-1, PD-L1, CTLA-4 family. But it's rare.
Thank you.
Thanks, Bob. Nice to see you again.
Good to see you all. Happy January, and COVID curve is going down. Things will be much better in 8 weeks. So there is light at the end of the tunnel, in my opinion.
Let's hope.
Yes.
Thank you.
So I'll send you the video and upload the lecture and the video for everybody else. Sorry, it kind of missed the beginning because I couldn't get it to record on my phone. So I hope it's so okay.
We're only a couple slides in. That's good. And then I'm going to send you an updated deck because I'm going to rechange the order a little bit, clean up the sequence. And then are we set for the next couple of months with Sarah for the other lectures?
I have to double check with her. I think we might need to schedule for the next month.
Okay, just email her and start working on the calendar. That would be great. Thanks for your help.
Thanks, Dr. Gish. Thanks, everyone.